Hello, my name is Kate Moody, and I am going to be talking to you today about my plan to improve ED throughput through the creation of an internal waiting room and decreasing the amount of time that patients spend in the front room process in the emergency department. I currently work as a nurse manager for an emergency department here at a busy hospital in Phoenix, Arizona, so this is something that I focus on a lot. Increasing ED throughput is directly correlates with better patient care and improved outcomes. So just a little bit of background on the issue. Emergency department overcrowding is a problem that is plaguing hospitals all over the nation. There is a high volume of patients that utilize the emergency department for primary and preventative care, and this has resulted directly in dramatically increased volumes and, as a consequence, longer wait times. All of this overcrowding has a big impact on the quality of patient care that is delivered, as it generates patient safety concerns, it decreases patient satisfaction, and adds to the amount of lost revenue for the hospital. The emergency department at the facility that I work at, which is Maricopa Integrated Health System, falls below many of the national benchmarks established for ED throughput. This indicates that a change is needed in order to bring the department up to the national standard. My argument is that it's in the best interest of the hospital to work towards improving ED throughput by implementing my plan so that these benchmarks will be met, which will have a direct impact on patient outcomes, patient satisfaction, and the hospital's overall budget. So what are these benchmarks that I keep talking about? The big benchmarks that I focus on in my plan are door-to-room and door-to-doctor times. What I mean by benchmarks is that there are national standards that have been established that kind of guide what is thought to be the standard of care. In the emergency department, a lot of these benchmarks revolve patient flow and throughput. Door to room is the amount of time that is how long it takes a patient to be in a treatment room from when they walk in the lobby. So from the time a patient walks in and says, I have chest pain, or I just want to be seen by a doctor, the amount of time it takes them to get back to a treatment room is what is your door-to-room time. The national benchmark for this is less than 25 minutes. At Maricopa Integrated Health System, we are above this. We are about 30 minutes. The second topic the benchmark that I want to focus on is the door-to-provider time. This is important because it's a measurement of how long it takes a patient to be seen by a medical provider, either a physician or a nurse practitioner or physician's assistant in the emergency department. The national benchmark for this is less than 25 minutes as well, with the best hospitals being at less than 5 minutes. At Maricopa Integrated Health System, our average is 27 minutes. So again, we are over this national benchmark. After an evaluation of ED processes, it's been established, or from what I saw, is that we're losing a lot of time in patients getting back to rooms from the lobby, so the door-to-room time. This obviously goes hand in hand with door-to-provider time, as providers are less likely to see patients if they're not in a patient room. What I want to do is create an internal waiting room, which is an area where patients, once they're triaged and deemed stable enough that they don't have to be emergently taken back to a room, that they can go and wait and be seen by a provider while they wait for a formal treatment room, and that provider can order initial treatments, lab works, medication, anything like that. This will help increase ED throughput, as the time that would otherwise be spent in the lobby is no longer wasted by a patient sitting in the lobby watching TV, talking to their family, or things like that. They can actually be receiving some medical treatment while they still wait for a formal room. These patients don't need to be in a bed or anything like that, so you can put a large number of patients, maybe 10 in a space, and have a tech or a nurse care for them and get these initial treatments and tests started. This will also improve patient satisfaction, as patients usually look for the first time that they are brought back to an area. It doesn't have to be a formal room, but a treatment room or a treatment area instead of waiting in the lobby. If they think that they're being seen, well, they actually are being seen, but if their perception is that they are being seen by a provider and by a nurse sooner, they are more likely to have a positive experience, and that will be correlated on their patient surveys that they receive in the mail afterwards, as well as they're less likely to leave the department without being seen. That problem, leaving without completing treatment, is something that plagues emergency departments who do have long wait times in the lobby. And those are not good to have because, one, the emergency department has been unable to provide a basic service that they're supposed to do, which is treat patients who need to come in and be treated. But additionally, it correlates directly with a large volume of lost revenue for the hospital. So by bringing patients back, getting them in an area where they can be seen, even on a smaller scale by a provider, have initial treatment started, feel like they're being seen and heard sooner, feel like they're not just wasting time not being cared for, that they're not viewed as important in the lobby, are all really big measures for patient satisfaction and patient care. It's important that we talk to the staff about this change prior to implementing it. It's not as easy as just opening up a space and saying, okay, this is where we're going. What we need to do is we need to talk to the nurses, to the techs, and to the providers and let them understand why this is such a big deal. Outline the reasons that I just said, that the hospital that we're working at currently falls below many of the benchmarks, and that it does have a direct impact on patient care, decreased revenue, decrease in patient satisfaction, and you run a higher risk of patients having complications in an area where they cannot be properly treated. It's important to let all the staff know why ahead of time and before you implement a process. So having meetings, having emails that go out and say why that this is such a big deal are really important for the staff to know that. It's really hard to create buy-in when there's not a full understanding of why the change needs to happen to begin with. After that, when talking about the change, when educating, it would be done through staff meetings where we'd outline the change, outline the process. There would be education done by our unit-specific clinical educator, who is another nurse who's been trained in educating staff. And on the medical side, there's usually a provider that is involved in continuing education for the providers, as well as it would be continued reinforcement through presentations of metrics over the course of the new plan. So that was a lot of jumbled words, I apologize, but basically what it means is we'll create the space, we'll talk with the staff about the need for the space, we'll make the necessary adjustments in the workflow, but then a large portion of this plan being successful is going to have to do with the constant reevaluation, updating the staff, letting them know how well the project is going, how our benchmarks have improved on a daily, weekly, and monthly basis so that they see the real-time results and the improvements from this, as well as regular and constant feedback from the staff, welcoming them to speak as to what's going well with the process, what could be improved, what barriers they have to success in the process. Over the course of that time, we can make small adjustments to things, increase staffing at certain times to allow for this plan, work with facilities to adjust the space as needed, continuing to talk to the providers who might be having a little bit of pushback. Again, just regular evaluation and making the staff feel like their feedback is heard is important in the process. Overall, these are simple adjustments that need to be made. It's not rocket science in the department. All nurses and all providers are really good at providing excellent patient care. It's the whole reason why they're in the job. All we have to do is show them how to do it more efficiently and actually give them a process through which they can care for patients quicker and better and more efficiently, which if you present it that way means that everybody should be on board.